Welcome back to the deep dive. We're doing something a little bit different today, and honestly, I think a lot of you are going to appreciate this one.
I think so too.
Usually, we are parsing through, a polished article from The Atlantic, or we're breaking down a dense academic paper with these perfectly cited sources.
Right, all very neat and tidy.
Today, we are getting our hands dirty. We are looking at, well, essentially, we're looking at a survival guide.
It really is. We are looking at a stack of handwritten study notes, some scribbles on slide printouts, a few coffee stains, all revolving around Chapter 60, AKI and CKD.
That's acute kidney injury and chronic kidney disease for those not up on the acronyms. And here is the vibe I'm getting from these documents.
Panic.
Controlled panic, maybe. I've seen this before. This is the handwriting of someone trying to download just a massive amount of complex pathophysiology into their brain about 48 hours before a high-stakes nursing exam.
And that is exactly our mission today. We aren't just reading these notes, we are decoding them. We are going to treat this deep dive as, like, the ultimate study session.
Yeah. We need to figure out what the scribbles actually mean, why certain numbers are circled 3 times in red ink, and most importantly, identifying the red flag questions that are hiding in this mess.
Exactly. Because when you are studying for a nursing exam, or really any clinical exam, you can't just memorize facts. You don't get points for knowing the Latin name for a kidney cell.
Right.
You get points and you save lives by understanding safety. You have to understand priorities.
Right. It's not just what is the kidney, it's what is going to kill my patient in the next hour if I miss it.
That is the perfect mindset to have. The exam is always asking, do you know what to do when things go wrong?
So we have a collection of notes here. We've got risk factors, the who, we have the clinical picture, the what, and we have the interventions, the what now. Let's start right at the beginning of the notes under the heading setup.
The etiology.
Yeah.
Who walks through the door?
Right. And looking at this first page of notes, there is a word written here. It looks like a typo, but I feel like it's crucial. It looks like Vidmel. Perfusion of Vidmel.
I spent some time staring at that one. Context clues are everything here. I think we can safely assume that is a frantic late-night scribble for vital organs, or perhaps visceral, or honestly, maybe they meant kidney and just forgot how to spell it in the heat of the moment. But the noun doesn't matter as much as the verb. The key word there is perfusion.
Perfusion. Let's define that for the listener who might know the word but doesn't, grasp the clinical weight of it.
Simply put, perfusion is the passage of fluid blood through the circulatory system to an organ or a tissue. In this context, it's life.
Just flat out, life.
The kidneys are incredibly needy organs. They are prima donnas. They receive about 20% to 25% of your total cardiac output.
That's a quarter of every single heartbeat going to 2 little bean-shaped organs.
Seriously, they need to be washed in blood constantly. If the kidney isn't getting blood, the kidney dies. It's that simple. It's not like a muscle that can ache for a while. Kidney tissue starts to necrose. It starts to die off.
Okay, so if the note says perfusion of whatever that word is, the student is reminding themselves, if the flow stops, the organ dies.
Yes.
Which leads us to the next scribble right underneath it. Big, bold letters. Hypovolemic shock.
Right. And dehydration right next to it.
So connect the dots for me. Why is shock the first thing on the student's mind? Why is that the top priority?
Think of the kidneys as a water treatment plant at the end of a river. The kidney is the plant. The blood is the river.
Okay.
If the river dries up, that's hypovolemic shock. You've lost blood from trauma, or you're severely dehydrated from the flu. There is just no volume in the vessels.
And if there is no volume?
There is no pressure. The kidneys run on pressure. They need that hydrostatic pressure to push the blood through the millions of tiny filters, the nephrons. If the pressure drops, the filtration stops.
The plant shuts down.
The plant shuts down. We call this a prerenal cause. The problem isn't the kidney itself. The kidney is sitting there ready to work, union workers ready to go.
But no materials are coming in.
The delivery trucks have stopped arriving.
And looking at the notes, there is a specific mention here of surgery and ARDS on ventilator.
This is a classic exam scenario. They love this one.
Why specifically those two?
Well, think about a major surgery. You lose blood. You are under anesthesia, which causes vasodilation. Your blood vessels relax and get bigger, which drops your blood pressure.
Right. The pipes get wider, so the pressure falls.
Exactly. And your body's under immense stress. That is a perfusion crisis waiting to happen.
And ARDS, acute respiratory distress syndrome, what's the connection there?
If a patient has ARDS, they are likely in the ICU. They might be septic, which causes massive vasodilation, again, dropping pressure.
Just the same mechanism.
It's the same pressure problem. Plus, they're on a ventilator with high pressures in the chest. That intrathoracic pressure can actually compress the major vessels and reduce the amount of blood the heart pumps out.
So the ventilator itself can hurt the kidneys?
It could reduce the flow. Again, it all comes back to flow. If the heart can't pump it, the kidneys don't get it.
So if I see a question on an exam about a patient who just had a massive hemorrhage in surgery, I should immediately be thinking, check the kidneys.
Absolutely. Because the body is smart, right? If you are losing blood, the body says, okay, I need to save the brain and the heart.
The essentials.
It clamps down on the vessels going to the kidneys. It actively shunts blood away from the kidneys to save the vital organs.
So the kidneys are the first casualty of war.
They are the sacrificial lambs. And that's why shock is written so largely there. It's the #1 trigger for acute kidney injury.
Now, shifting gears slightly, there is another word here, just standing alone in the margin. Older. Just the word older.
Simple, but huge. Age is a massive independent risk factor.
Is that just because older people get sick more often, or is there more to it?
That's part of it, but it's also structural. As we age, we just lose nephrons. A healthy 80-year-old has significantly less renal reserve than a 20-year-old.
So they have less of a buffer.
Think of it like a spare tire. A 20-year-old has a full spare tire in the trunk. An 80-year-old is driving on a donut.
So if they hit a pothole...
They get a flat immediately. Their ability to bounce back from dehydration drops. Plus, their thirst mechanism is blunted. They don't feel thirsty as easily.
Oh, that's a problem.
It's a huge problem. So an 80-year-old who gets the flu and stops drinking water is in much bigger danger of kidney failure than you or I would be.
Okay, so that's the flow problem, the river drying up. But then I see a scribble down here with an arrow pointing to obstruct the flow of urine.
Okay, different category.
And there are specific examples. Kidney stones and enlarged prostate tumor.
Okay, so if the first category was the river drying up, this category is someone building a dam.
A dam.
This is a post-renal problem. Post meaning after the kidney. The kidney is working fine, it's making urine, but the exit is blocked.
The plumbing is clogged.
Exactly. Imagine a garden hose. If you turn the water on full blast, that's the blood flow coming in, but you put your thumb over the end or you kink the hose. What happens to the pressure inside the hose?
It builds up, it expands, the hose gets hard.
It skyrockets. And in the body, that back pressure goes right back up the ureters and into the kidney pelvis. And that pressure destroys the kidney tissue.
It literally crushes it.
It crushes the nephrons. We call it hydronephrosis.
So an enlarged prostate that's squeezing the urethra.
Correct. The urine can't get out of the bladder fills up, then the ureters fill up, and it backs up into the kidneys.
And the note mentions tumor specifically.
Yeah, a tumor in the pelvis, a stone in the ureter, a prostate, anything that blocks the exit.
So for the exam, if the patient says, I haven't peed all day, but my bladder feels really full, or I have this really bad pain in my flank, we are thinking obstruction.
You are thinking obstruction, post-renal, and you need to fix it fast.
Why so fast?
If you relieve the obstruction, put in a catheter, remove the stone, the kidney can often recover quickly. But if you leave it, that back pressure causes permanent damage. It's a race against time.
Okay, so we have no flow in, which is shock, and we have no flow out, which is obstruction. But what about the kidney itself? I see infection, lupus, and cancer written here.
This is the third category, intrarenal.
Yeah.
The damage is inside the factory.
The workers are on strike?
Or the factory is on fire. Lupus is an autoimmune disease. The body's own immune system attacks the kidney tissue.
So the body attacks itself?
It does. Infection, like pyelonephritis, attacks the tissue directly. And certain drugs, we call them nephrotoxic drugs, can directly poison the cells inside the kidney.
Like contrast dye for a CT scan.
Contrast dye is a big one. Certain powerful antibiotics like vancomycin, they can be really toxic to the factory workers.
So essentially, when we are looking at risk factors for the exam, we are categorizing them. Is it a flow problem, a plumbing problem, or a damage problem?
Precisely. And that is the key to the exam. If you can figure out which category it is, you know how to treat it.
Right.
If it's a flow problem, you give fluids. If it's a plumbing problem, you remove the obstruction. If you give fluids to a plumbing problem, you just increase the pressure and make it so much worse.
That makes perfect sense. Let's move to part 2 of these notes, the clinical picture, because this student has written down some very scary-looking symptoms.
This is the assessment phase. What does the patient look like when you walk into the room?
There is a phrase here that I want to zoom in on, waste in blood. And right next to it, connected by a shaky line, is the word confusion.
This is a huge safety red flag. Capital S, capital R, capital F.
Why?
What do the kidneys do? I mean, what's their main job? They filter out toxins, urea, ammonia, creatinine, metabolic trash.
Right.
If the kidneys stop working, where does that trash go?
It stays in the blood.
It circulates. And when those toxins, especially urea and ammonia, hit the brain, they cross the blood-brain barrier. They cause encephalopathy. They cause confusion.
So the patient isn't just tired, they are actively confused.
They might be lethargic. They might not know where they are. They could be agitated, picking at their sheets. And for a nurse, confusion is a safety priority.
Why?
A confused patient falls. A confused patient pulls out their IVs. A confused patient tries to walk home in their hospital gown. It's a major safety issue.
So if I see an exam question that says, your patient with chronic kidney disease is suddenly disoriented, that's not a neurological primary problem. That's the kidneys failing to filter.
Exactly. It tells you the toxins are reaching critical levels. It's a waste product accumulation. You check their BUN, blood urea and nitrogen, and their creatinine immediately.
Okay, that's the brain. Now let's talk about the body. The notes are absolutely covered in fluid warnings. I see edema, crackles, jugular vein distension or JVD, and thirsty.
This is a classic wet patient.
The wet patient.
Remember, if the kidneys aren't peeing out the water stays in the body. You become a closed system.
You become a water balloon?
You basically become a water balloon.
And the notes connect heart disease to these symptoms. It says heart with a big arrow to disease and then to all these symptoms.
The heart and kidneys are like a married couple. If one is having a bad day, the other one suffers. We call this cardiorenal syndrome.
Cardiorenal.
If the kidneys fail and fluid backs up, where does it go? It overloads the vascular system. The heart has to pump all that extra fluid. It gets overwhelmed, it stretches, it fails.
And that leads to JVD, those bulging neck veins.
Right. That's the blood backing up because the heart can't pump it forward fast enough against all that fluid. It backs up into the jugular veins. You can see it clear as day.
And crackles. You said that's a big one.
That is the most dangerous one on that list.
Why?
Crackles means fluid in the lungs. Pulmonary edema. The fluid has nowhere else to go, so it seeps into the alveoli, the air sacs. This creates an oxygenation problem. The patient is, for all intents and purposes, drowning.
So edema in the ankles is uncomfortable. Crackles in the lungs is deadly.
Precisely. On an exam or in real life, airway and breathing always take priority. Always. You can live with swollen ankles. You cannot live if you can't breathe.
We are going to come back to crackles in a minute because there is a very specific intervention note about that.
A crucial one.
But first, I want to talk about the vitals. The note says vital signs still, or maybe monitor vitals still, but it mentions arrhythmias.
Yes, arrhythmias.
Now, the note doesn't explicitly say potassium, but when you see arrhythmias in a kidney context...
You screen potassium in your head.
Okay. So why is that connection so strong?
Kidneys are responsible for balancing electrolytes, specifically getting rid of excess potassium. We eat potassium in everything, fruits, vegetables, you name it.
Right.
If the kidneys stop, potassium builds up, hyperkalemia. And high potassium is incredibly toxic to the heart's electrical system.
What does it do?
It makes the heart twitchy and irritable. It causes peak T waves on the ECG, and then it progresses to lethal arrhythmias like ventricular tachycardia or fibrillation. The heart just stops.
So, on an exam, if a kidney patient has an irregular heart rate...
You are checking their potassium level immediately. That is a medical emergency. You are getting an ECG stat. You are not waiting.
Okay. So we have a confused patient who is swollen, having trouble breathing with these crackles, and might have an irregular heartbeat. This sounds like a train wreck.
It is a train wreck. That is why AKI, acute kidney injury, is so serious. It affects every single system in the body.
Let's talk about the output. There is a number written here. It's underlined. It's circled. Decrease then 30 an hour.
The golden number.
30 ml per hour. Why 30? Is that just an arbitrary number someone picked?
It's not arbitrary at all. It's based on physiology. Roughly 0.5 millimolars per kilogram of body weight per hour is the minimum needed to keep organs perfused. For an average adult, that comes out to about 30 milliliter.
Visualizing that, 30 millimol is like a shot glass.
Essentially, yes. A standard shot glass is about 30 to 45 milliliter. So if your patient isn't producing even a shot glass of urine in an hour, you are in the danger zone. The factory is shutting down.
And the note says decreased, then 30. So if I'm the nurse and I empty the catheter bag at 9:00 a.m. and there's 100 ml, I'm happy. But at 10 a.m., there's 20 ml out.
You are calling the doctor. You're on the phone.
That fast. I don't wait another hour to see if it picks up.
No. In the world of AKI, time is tissue. That drop is a trend. It indicates the kidneys are shutting down now. Maybe the patient is going into shock. Maybe the catheter is kinked. But you have to investigate immediately.
What about this other note? Dilute urine. It seems contradictory. If they aren't peeing, wouldn't the urine be dark and concentrated?
That's a great catch. This happens in certain phases of kidney failure. The kidneys lose the ability to concentrate the urine. The mechanism that pulls water back into the body fails.
So it's just letting water pass through.
Exactly. So what little water comes out is just water. It doesn't have the toxins in it. It's not doing its job.
So clear urine isn't always good urine.
Not in this case. We want the urine to carry the trash out. If the urine is clear but the blood is full of trash, with a high BUN and creatinine, the kidneys aren't doing their job. We want that urine to be yellow. That means it's full of urea.
Okay, let's shift gears to part 3 of these notes. The strict interventions. We know what the problem looks like. What do we do? The notes say, strict INO.
Intake and output, and when they say strict, they mean strict, not sort of INO.
Explain the difference between regular INO and strict INO.
Regular might be asking the patient, hey, did you drink that water on your tray? And they say, yeah, most of it. You write down about 100 millibel.
That sounds pretty loose.
It is. Strict means you measure everything. You use a graduated cylinder. Every milliliter of IV fluid, every sip of juice, every spoonful of gelatin, every ice chip.
And the output.
You measure every drop of urine. You measure vomit. You measure wound drainage. If they have diarrhea, you measure that. You need to know the exact balance.
Because the margin for error is 0.
Exactly. If you give them 500 millibel and only 50 comes out, you know that 450 milliliters is sitting in their lungs or their legs. You are balancing a checkbook where an overdraft kills the patient.
Which leads right to the next note. Daily weights.
The single most accurate indicator of fluid status. Hands down.
More than edema. More than checking if their ankles are puffy.
Yes, edema is subjective. Oh, his ankles look a little puffier today. That's a guess. But weight. 1 kilogram of weight gain equals 1 liter of fluid retention.
It's just math.
It is math. It is objective.
That's a 1-to-1 conversion.
Roughly, yes. So if a patient gains 2 kilograms overnight,
they are retaining 2 liters of fluid? That's a massive amount of fluid.
It is. It's a huge amount for a heart to handle. Imagine dumping a 2-liter bottle of soda into your veins. That's the stress you're putting on the system.
Okay, so we are weighing them every morning. Same scale, same clothes.
Same time. Usually before breakfast, after voiding. Consistency is key so you can track the trend.
Now, let's talk about the fluids themselves. There is a very specific restriction written here. Fluid restriction 1500 24 HR period. 1500 millifel per day. That is the limit.
And that includes everything.
Everything. The water with their pills, the coffee on the tray, the IV antibiotics, the soup at lunch, all of it.
The expert note here implies that students often have to do math here on exams.
Oh, they love these questions. It's a classic nursing school problem. The patient is on a 1,500 millibel restriction. They had 300 millibel for breakfast, 500 millibel of IV fluids during the day, and 400 millimel for lunch. How much can they have for dinner?
Let's see, 300 plus 500 plus 400 is 1,200. So they have 300 left for the evening shift.
Exactly. And as a nurse, you have to police that. You can't let the day shift give all the fluid and leave the night shift with 0.
Oh, yeah.
The patient will be screaming with thirst. You have to plan it out with them.
Thirsty was one of the symptoms in the notes.
It is. It's cruel, really. Their body is overloaded with the fluid. They are literally drowning in it. But the cells are screaming for water, and the high toxins trigger the thirst center in the brain. So they feel desperately thirsty even though they're full of water?
Yes, but you must enforce the restriction. It's a life-saving measure.
Okay, here is the big one, the stop order. This note is scribbled with some urgency, I think. It says, if they're not eating, drinking, give fluids, but you would watch for crackles, stop infusion, and call DOGR.
This is a failure to rescue scenario. This is critical. This is where you pass or fail the exam and where you save or lose the patient.
Walk me through this. Let's build the scenario. I have a patient. Maybe their kidneys are dry. Maybe it's that pre-renal shock we talked about.
Okay.
So the doctor ordered fluids to perfuse the vidmel, right? To perfuse the kidney.
Right. So you are running an IV bolus. You are dumping fluid in to try to increase the pressure and wake up the kidneys.
But then I do my assessment, I listen to the lungs, and I hear crackles.
The moment you hear crackles in the lungs, the game changes instantly.
Oh.
Because it means the kidneys aren't waking up. The tank is full.
Yeah.
The fluid isn't going into the kidneys to make urine. It's backing up into the pulmonary vasculature.
It's going into the lungs.
If you keep infusing, You're drowning the patient. You're filling their lungs with water.
So the intervention is?
Stop the infusion immediately. Do not finish the bag. Do not call the doctor first. Stop the pump.
Stop the pump.
Then assess the patient. Check their oxygen. Sit them up. Then call the doctor.
That is a classic exam trap, isn't it? What is the priority action? A, call the doctor. B, document the findings. C, stop the infusion.
And the answer is always C, stop the harm. If you stay on the phone explaining the situation to the doctor while the pump is running at 200 mil/A, you are actively harming the patient.
I can see the students stressing over this note. Watch for crackles, stop infusion. It's the pivot point between helping and hurting.
It really is. It's the delicate balance of kidney care. Give enough fluid to flow, but not enough to drown.
Now let's move to part 4, pharmacology. Do no harm. The note here is about diuretics. Diuretic use, caution, big dose, could shut kidneys down.
This seems counterintuitive, right? That throws a lot of people off.
Yeah. Diuretics like Lasix or furosemide make you pee. If the patient isn't peeing, shouldn't we give them a huge dose of Lasix? Just force it out.
It's a double-edged sword. Yes, we use diuretics to try to kickstart the flow, but if the kidney is truly damaged, if the nephrons are dead or dying, whipping the horse won't make it run faster.
It just kills the horse.
It just kills the horse.
So a big dose can actually cause more ischemia, more damage.
It can deplete the volume in the blood vessels so fast that you cause more hypovolemia, you dry out the river even more, or the drug itself can be toxic in high concentrations if it's not being excreted.
That leads to the next note. Risk for any overdose on drugs.
This is Pharmacology 101 for kidney patients. The kidneys are the body's bouncer. They kick the drugs out of the club when the party's over.
And if the bouncer is asleep?
The drugs stay in the party. They stay in the blood. So a normal dose of painkiller or antibiotic or heart medication, it stays in the system for days instead of hours. The half-life extends indefinitely.
So the levels become toxic.
Exactly. So for a kidney patient, you often have to lower the dose. You have to renally dose the medication. If you give a standard dose of vancomycin or digoxin to a patient with renal failure, that might kill them.
So on an exam, if I see a medication order for a CKD patient, I should be checking. Is this dose appropriate for their kidney function?
Always check the dose. And check the trough levels. You are the last line of defense against toxicity. The pharmacist and the doctor are there, but the nurse at the bedside is the final check.
Let's talk about food, the renal diet. The note says, have dietitian to come educate pain.
It's not just about pills. It's about lifestyle. And this is a huge part of it.
What is a renal diet? What are we telling them to avoid? Based on what we've discussed so far, I can guess a few.
Well, based on the killers. What kills them?
Fluid.
So fluid restriction. What else kills the heart?
Potassium.
So low potassium. No bananas, no avocados, no potatoes, no oranges, no tomatoes.
That's like all the good fruits and vegetables. That's a huge list.
It is. It's a very restrictive list. And what about the waste products?
Urea comes from protein breakdown.
So we often restrict protein because we don't want to create more trash for the kidneys to handle.
Yeah.
And finally, sodium.
Salt holds water.
Exactly. If you eat salt, you swell up. So low sodium.
Man, that is a tough diet. No salt, low protein, low potassium, fluid restriction. What is left to eat?
White rice, white bread, maybe some applesauce. It is a miserable, bland diet. That's why the note mentions patient education. You can't just hand them a tray and walk away.
You have to explain the why.
You have to explain why that banana is dangerous, why that salt shaker is a weapon. If they don't understand the physiology, they won't follow the rules.
Which brings us nicely to part 5, the human element and logistics. I love that this student, amidst all the panic about creatinine and crackles, wrote down extra support, counselor, and getting to appointment.
I noticed that too. It's a good reminder that we're treating a person, not just a kidney.
Why is this here? Why is it so important in this context?
Because chronic kidney disease is life-altering. You are tethered to a machine if you are on dialysis. You go 3 times a week, 4 hours a day.
That's a part-time job.
It's a part-time job you hate. You can't travel. You can't eat what you want. You can't drink when you're thirsty. You feel like garbage because of the toxins. Depression is massive in this population.
So extra support isn't just fluff. It's a clinical intervention.
Absolutely. If they are depressed, they don't take their phosphate binders, they don't stick to the diet, they cheat on fluids, they end up in the ER with fluid overload. Mental health is physical health here.
And getting to appointment, that seems so basic.
It's basic, but it's life and death. Dialysis is life support if you don't have a car. If you don't have money for the bus, you miss a session.
And if you miss a session...
Your potassium spikes, your fluid builds up, and you can die before the next appointment.
So the nurse asking, hey, how are you getting to the clinic on Tuesday, is actually saving a life.
It is as important as the medication.
Yeah.
Social work, case management, it's all part of the plan of care.
Finally, there is a just admitted checklist. It looks like a summary of everything we've talked about.
The standard protocol. The first things you do when this patient hits the floor.
Read it off for me.
Strict INO, monitor lung sounds, daily weights, vitals.
It's simple, but if you do those 4 things, you catch the problems before they become catastrophes.
You catch the trend, you catch the fluid retention before the lungs flood, you catch the shock before the kidneys die, you catch the arrhythmia before the heart stops. It's all there.
Okay, we have covered a ton of ground. We decoded the vid malperfusion, we unplugged the plumbing obstruction, we watched for the wet symptoms, and we stopped the IV when we heard crackles.
We did. We just crammed the entire chapter in, I think.
For the listener who is jogging or driving right now and just needs the cheat sheet for the exam, give me the top 3 takeaways, the absolute must-knows.
All right. If you remember nothing else, remember these 3 things.
Output. Watch for less than 30 millilhr. That is your early warning siren. If it drops, you act.
Okay, number 1 is output.
Number 2, lungs, crackles, stop fluids. Airway and breathing take priority over restarting the kidneys. You can't perfuse a dead patient.
Lungs, stop the fluids. Got it.
And number 3, safety. Confusion comes from toxins. Protect the patient from falls. And safety with drugs watch for toxicity because the bouncer is asleep.
Perfect. Verdi, MLO, crackles, confusion.
That's the triad. If you watch for those 3 things, you'll be safe.
I want to leave the listeners with one final thought. There was a weird little phrase in the notes, wait to zoom in on this.
Wait to zoom in on this. I like that. It's very meta.
What does that mean to you in this context after everything we've discussed?
In kidney care, you have to have a dual lens. You have to zoom in on the tiny details, the milliliters of urine, the slight change in potassium from 5.1 to 5.3, the 1 extra kilogram of weight. Those tiny details matter.
But you can't get lost in them.
You can't. You have to zoom out to the whole body, the heart failing, the brain getting confused, the lungs filling up. You have to see both the micro and the macro at the same time.
The kidneys really are the scorekeepers of the body, aren't they? They tell the story of what's happening everywhere else.
They are. They're the silent accountants. And when the accountants go on strike, the whole economy of the body collapses.
Well, on that cheerful note, go zoom in on your own studies. Good luck in the exam. You've got this.
You've got this.
Thanks for listening to The Deep Dive. See you next time.